try to offer this service as the Centre, as the Centre for Mental Health. The best thing we ever did, I think, was to go over to Dartmouth. And they have had for a number of years in the United States what's called the Johnson & Johnson program, because it's sponsored by the big pharmaceutical company, which we don't do. It's sponsored by them, and it's about spreading evidence-based supported employment across the United States. And it's based on the principle of having a state trainer who works intensively with a service within a particular area and then moves on. So it's a way of getting services going by working alongside them. A bit like training employment specialists. The whole thing is a process of hand-holding, learning, continuous reflection. And the state trainer program has now got a position where I think in the last year they had about 8,000 people in the program who are actually being supported in employment. And we've been trying to do a bit of this. We've now got what we call a regional trainer. Couldn't call it state training because we don't have states over here. We call it regional trainer and development work. And we've got one of those in Sussex now, trying to develop services in the way the Johnson & Johnson program does in the United States. We also, not only did we go over there to see what was going on, but we also attended one of their state trainer training programs, and that was the best thing for our leaders that ever happened. And interestingly, and you might like to make a little note of this, we've got Sarah Swanson, the Dartmouth people, coming over in February of next year to run a course for leaders in our country, so that we can start to run that ourselves. And you know, that course isn't full yet, if you're interested in doing that. We also have been discussing for quite some time a learning network. We already have one, actually. We work by email largely, and occasional visits very closely with the United States, with Australia, with Canada, New Zealand, and we're starting to do work with Spain, Holland, and basically it's a collection of enthusiasts who keep together by email. But we do have a very large chunk of time at the next World Congress of Psychiatry in Argentina in 2011, where we're all meeting to run a whole set of sessions on IPS. It's the first time we've done this in the big psychiatric congress, and most of us are paying to do it ourselves, actually. Don't get paid to do these sort of things. So the beginnings of an international learning network, and really anyone is welcome, and I would hope that AMH will consider joining that program. So that's what we're doing. I'm reaching a conclusion now, really. Basically, I'm saying we have the information. The piece of briefing paper 37 that you can see outside, if you grab one or perhaps grab one when you leave, that gives you the evidence. That talks about the evidence that I've just given you today. Measuring what matters is how you count outcomes. What are the kind of process, what are the kind of outcome indicators you might want to use in measuring your service? I don't think we got this right yet. This was a first attempt at it. We're still struggling with this one. But it's a starting point. Commissioning what works talks about the cost-benefit analysis of IPS in the short and in the long term. It tells you what services cost, it tells you what the returns are over time. If I were to just give you then a couple, someone in Spain asked me the other day, what if you had two things to say, what would it be out of all the things you said? And I say, well, the first one is integrate your clinical and your employment services. Make sure that they're together. And the second is don't ever allow anyone to abandon hope. That's the whole thing. That's the whole of it, really. If you believe, then that will mean that your people will believe and that they will ultimately get work. As a professional, it is your duty to be hopeful, and that's my final point.